Hello, everyone, and welcome to today's Lunch and Learn webinar. We're excited today to talk about this important topic of unexplained arterial thrombosis, approach to diagnosis and treatment. We have presenter Jori with us today, as well as my co-chairs and panelists for today's discussion. So the idea for this webinar came from Dr. May and Stefan Mall, longtime friend of the AC Forum, their paper on unexplained arterial thrombosis, which walks really well through this topic. And so we're going to be focusing on this today. Next slide. So these will be the folks on the call on the webinar. We have the privilege of having the lead author, Jori May, hematologist and assistant professor, University of Alabama in Birmingham. And then we have my co-moderators, Andrea van Beek from Visalia Medical Clinic, and Deborah Siegal, hematologist, thrombosis specialist at Ottawa Hospital Research Institute. These are the disclosures for today's lecture. Next slide. And this is an accredited program. So we'll show you this again at the end of the program, and I believe this will be put in the chat for you to be able to claim your CE. At this point, I'm going to hand it off to Dr. May for the presentation.
Well, thank you, Arthur, and thanks so much to the organizers for having me today. Excited to talk about this topic together. So let's talk about first our objectives here. So we are going to present a structured approach to the diagnosis and management of unexplained arterial thrombosis. And I'm along the way going to try to highlight some common pitfalls and areas of controversy in the diagnostic and management process for these patients. So when I say unexplained arterial thrombosis, what do I mean by that? So there's a couple of things that we factor into play when we think about a truly unexplained arterial thrombotic event. First is the location of the thrombus. So there are the usual sites of arterial thrombosis that we think about, things like ischemic stroke, myocardial infarction, peripheral artery occlusion. Those are areas where we expect and unfortunately see thrombosis quite commonly. But there's other sites like retinal artery occlusion, LV thrombus, splenic or renal artery occlusion, intestinal artery occlusion, that we often fall in this unexplained category, or there may not be a really obvious explanation. But in addition to location, we tend to think about an unexplained arterial thrombotic event as one that's happening in a younger patient. We expect to see arterial thrombosis in older patients due to multiple risk factors, but not necessarily in younger patients. And then really, these are events that don't have a very obvious atherosclerotic or cardioembolic risk factor. So as an example, an unexplained arterial thrombotic event per this definition would be maybe a stroke occurring in a younger patient without clear atherosclerotic or cardioembolic risk factors, or maybe a retinal artery occlusion in an older patient, but without a clear etiology. So how do we approach these patients? I'm going to present the framework that we presented in our paper to talk about how we think about these patients. The challenge is that it's really difficult. There's many things that could potentially be contributing. And so what we propose here is really taking a very structured approach to make sure all potential options are considered. I'll emphasize here that we're spending a lot of time talking about the diagnostic process rather than jumping straight to the management process. And the reason for that is that the cause of the thrombotic event is really central to the determination of appropriate management. So we spend a lot of time making sure that we've explored every potential explanation for the event before we start making decisions on how we manage these patients. So we'll start first with what we call defining the clot. And this may seem straightforward, but particularly in these patients with unexplained events, it's really essential to really understand the location of the clot and the extent of injury. As an example, sometimes arterial events can be mischaracterized and are actually venous events. So you can have ischemia to an organ like the kidney or like the spleen, and that can be due to an arterial event, but it can also be due to a venous event that leads to passive congestion and then leading to infarction of the tissue. So reviewing the imaging with a radiologist to make sure that we are truly talking about an arterial event can be really helpful. If you have any other tools at your disposal like pathology, that can be helpful to review as well, and making sure that you're collaborating with an organ-specific specialist, because when we're thinking about how to ensure that we are fully understanding where the thrombotic event is, there's often organ-specific features that we should consider. I then at that point also like to think about performing an organ-specific literature review. Again, the variation in how we diagnose these patients, the potential causes and the potential treatments vary significantly based on where the thrombotic event occurred. So I look for comprehensive reviews or any recent updates in the field before venturing down the diagnostic pathway. So once we've defined the clot, we talk about entering a diagnostic evaluation. And we've divided this into 6 categories of conditions, again, to try and be very deliberate and make sure that we're exploring all potential causes. We start with the 2 most common on purpose, right? Arterial thrombosis is most commonly due to atherosclerosis or embolic causes. And the workup for these most are quite familiar with, but I do want to highlight a couple of things where these are people who don't have kind of an obvious etiology. So how do we take that workup a step further in order to make sure we've fully ruled out atherosclerotic or embolic causes? When we think about imaging, there's a couple of things that I like to remind myself. The first being that the degree of stenosis in the setting of atherosclerosis does not necessarily correlate with the likelihood of an atherosclerotic etiology or the potential for plaque rupture. We've seen this in multiple sites of atherosclerosis, and so I do look at imaging in order to see if there's any evidence of atherosclerosis, even if it may not be significantly stenotic. Important to think about when you're evaluating for embolism, we're looking for things like patent foramen ovale or valvular abnormalities that really transesophageal echo is the gold standard to evaluate for these abnormalities. We often use a transthoracic echo because it's less invasive, and this is an appropriate screening modality for initial evaluation. But in these patients with an unexplained arterial event, it's often reasonable to consider a transesophageal echo as well. Cardiac monitoring in the ambulatory setting is an area of controversy. Understanding how long we need to look for occult arrhythmias is really debated. There was a recent publication looking at the ability of implanted loop recorders, which obviously provide a longer duration of monitoring, may increase the detection of atrial fibrillation, but they did not appear to decrease the rate of recurrent stroke. So there's question of whether if we are monitoring for a longer period of time, are we potentially picking up on arrhythmia that may not be clinically significant? At this point, I often think about a standard 30-day monitor, or sometimes if 14-day is only available, but it's certainly an area of debate in this topic. We're all quite familiar with the standard evaluation for cholesterol and diabetes and other risk factors for atherosclerosis. But a newer marker is being explored, which is lipoprotein A. It's a low-density lipoprotein that seems to correlate with cardiovascular risk outcomes. Guidance document cited here does recommend testing for lipoprotein A elevation in patients with premature atherosclerotic cardiovascular disease or ischemic stroke. And the criteria they use for that is an age in males less than 55 or less than 65 in females. So our unexplained arterial thrombotic patients may fall into this category. It's also recommended in patients with a family history of premature ASCVD. And the reason testing for this is important is that we do have dedicated therapy to target lipoprotein A elevation with PCSK9 inhibitors. So I have incorporated this into my workflow in evaluating these patients because we do have new treatment options to address it. So if after we've explored atherosclerotic or embolic causes, we then move into the rarer causes of unexplained arterial thrombosis. So certain medications and substances can increase the thrombotic risk. However, what we know about most of these medications is really we understand more their ability to increase venous thrombotic risk rather than arterial. So some of this is extrapolated from venous thrombotic risk evaluations. And the other limitation is that when there is arterial thrombotic risk documented, it's really primarily seen in, we're talking about myocardial infarction or stroke, rather than these other rarer sites of arterial thrombosis. So there's no good data to tell us for sure which medications might correlate with that risk. This is a very brief list of some of the medications that are more common that you might consider looking for in a patient with an unexplained arterial event. We know that estrogens and anabolic steroids can increase the risk of stroke and myocardial infarction. Again, their role in those rare sites of thrombosis is unclear, but I do think about those. We can't forget heparin-induced thrombocytopenia as a reaction to heparin, which certainly can cause arterial events and can occur, remember, in patients even that may not be truly thrombocytopenic. So this should be a consideration in all hospitalized patients. IVIG has shown to increase arterial thrombotic risk. Certain substances like cocaine, which can cause vasospasm or arterial remodeling, and then tobacco, which can cause thromboangiitis obliterans, other things that can lead to peripheral artery findings. So we do think about substance use history and tobacco use. Looking for other agents that are more disease specific, so ESAs or anti-cancer therapies, there are some of those as well will correlate with arterial thrombotic risk. So the take home here is to make sure we do review medications with patients and think about any non-prescribed substances that they might be taking as well. Next, we move into the category of vascular or anatomic causes. And I like to think of this in two categories. First, those things that interfere with vessel structure and those that interfere with the vessel caliber. So what are things that cause abnormalities with the vessel structure that may predispose to arterial thrombosis? These are things like dissection, aneurysm, or fibromuscular dysplasia, where the disruption in arterial flow can lead to arterial thrombosis development that can even then embolize to other locations, even if the thrombosis isn't at the direct site of the arterial abnormality. And then we think about things that can affect the vessel caliber. So external compression, vasospasm, which can be due to medications, or can also just be related to certain conditions, often autoimmune diseases. So to evaluate for these things, I think about reviewing any sort of existing imaging, making sure that there's no obvious signs of vessel abnormalities on what we already have. And if there is clinical suspicion, thinking about dedicated arterial imaging, so a CT angiography or MR angiography, or even traditional catheter-directed angiogram if that might be indicated in a patient. Then we move to a pretty large category. So systemic disorders can mean a lot of different things. And so I find in my workup, I do spend a lot of time in thinking about making sure that this arterial thrombotic event is not an indicator of another broader process going on in the patient. So I've grouped here malignancy and autoimmune disorders in the same category because these conditions often have overlapping workup. We know that malignancy increases arterial thrombotic risk. We have some studies that show an increased arterial thrombotic risk, particularly in the 6 months after diagnosis, but often that arterial thrombosis can even precede a malignancy diagnosis. Autoimmune conditions can be associated with an increased inflammatory state that can lead to thrombotic events. We also think of disorders like vasculitis of different size vessels that can also lead to arterial thrombosis. So consideration of both of these categories is really important. So I spend a lot of time performing a very thorough history and physical with a patient, asking specific questions about any new or associated symptoms that might direct me towards a specific diagnosis. I like to review the imaging in great detail to make sure there's no sign of any sort of malignant disorder or a finding that would indicate the presence of other or systemic problems. I make sure that the patients had what I would consider to be age or risk appropriate cancer screening based on guidelines. There has been data in venous thrombosis looking at doing more extensive imaging, full CT scans in order to look for malignancy in a patient with an unexplained venous event. And that did not really demonstrate any benefit. And so even though we don't have this data in arterial thrombosis, I tend to take the same approach. And so only getting additional imaging if there's specific symptoms and just making sure the patient has had their appropriate cancer screening. For autoimmune conditions, we think about, do we need to check for inflammatory markers? Do we need to look for an active urine sediment? If a patient does have symptoms, are there additional serologies that would be helpful for pursuing an autoimmune disorder? All of that can be considered. There are certainly hematologic disorders that we know increase the arterial thrombotic risk. The two most common that we think about are myeloproliferative disorders and paroxysmal nocturnal hemoglobinuria. In general, I think about first getting basic blood counts and looking for any signs of low blood counts or high blood counts that might point us towards one of these diagnoses. It's controversial whether there's a need to test for these disorders in the absence of a change in the blood counts. I think about that only in rare cases, but it is important to consider these diagnoses because we know they have a correlation with increased thrombotic risk. There's other hematologic disorders. I think about those that create kind of a hyperviscosity syndrome or increased plasma proteins, such as cryoglobulinemia or plasma cell disorders that are worth considering as well. Other blood disorders like sickle cell disease may increase thrombotic risk. And so exploring these with blood counts and additional testing is always important. Unfortunately, we can't have a talk these days without talking about COVID-19. And so what we know about COVID infection is that it does seem to increase arterial thrombotic risk. Importantly, this data is from the initial strains of the virus and at a time when we didn't have vaccination. So it's hard to extrapolate or know if that arterial thrombotic risk continues with these later strains of the virus and in people who maybe are vaccinated. But certainly it's something that I consider and look for in a patient with an unexplained arterial event. What about vaccination? We do know the rare complication of the two formulations, the AstraZeneca and Johnson vaccine, called vaccine-induced thrombotic thrombocytopenia, causes a syndrome similar to HIT that can lead to arterial thrombosis. Importantly, the available data that we have on other vaccine formulations and those vaccine formulations outside of VIT do not appear to increase venous thrombotic events. There's not kind of clear data on evaluating arterial thrombotic events, but at this time, there does not seem to be an increased risk. And I do not consider that a risk factor at this point. So last, we move to the category that I, as a hematologist, am often called on to address, the concern that there's some sort of thrombophilia. And this is deliberately placed at the end of our evaluation. And the reason for that is that we don't have great data to tell us what to do here. I'm going to present a summary of our approach and recognize really there's a lot of limitations to what we know about the role of thrombophilias in arterial thrombotic risk. So I'll cite two additional references that you might consider if you want more information on this topic. Dr. Mall and I did a previous review on how the inherited thrombophilias influence arterial thrombotic risk. We did that in detail. And I will say that since the publication of the paper that I'm discussing today, the British Society of Hematology has released new guidelines that discuss thrombophilia testing, not only in venous thrombosis, but arterial thrombosis as well. And they do speak quite conservatively in that they don't recommend testing for the majority of events. I encourage you to look at those guidelines. But I'll present to you here my current approach based on the limitations we have in the literature. So the challenge is that the data that we do have is primarily retrospective studies, very small patient populations, and certainly not in these unexplained arterial thrombotic locations. And furthermore, we don't have any data to tell us if we find the thrombophilia, if we need to manage that patient any differently. Is that a patient that needs aspirin or anticoagulation? We don't know. So when I think about the thrombophilias, I think about kind of three categories: those that do not have a clear clinically significant effect on the arterial thrombotic risk, those that have a possible effect, and those that have a definitive effect. And so when I think of those that don't have a significant effect, I think of the weaker thrombophilias where patients are heterozygous for factor V Leiden or a prothrombin mutation. Available data suggests there may be a slight increase in risk, a risk that I don't think is clinically significant at this point and that does not tend to influence my management. Those that have a possibly significant effect are those that we refer to often as the stronger inherited thrombophilia. So patients that are homozygous or compound heterozygotes for factor V Leiden or the prothrombin mutation, and then deficiencies in protein CS and antithrombin. So I do think about testing patients for these disorders if we've looked for all other causes. If this is a young patient, particularly with a family history of thrombosis, perhaps that's worth exploring. Antiphospholipid syndrome often gets grouped in with these testing, but it's important to remember that antiphospholipid syndrome is an acquired disorder. It is not an inherited disorder, and it is a disorder with a very clear increased risk of arterial thrombosis. So importantly, when we're testing for antiphospholipid syndrome, we recommend staying within the guidelines of how to test for those. I've cited those guidelines here if you want more information on how to appropriately test for antiphospholipid syndrome. But I do think about testing for this very frequently in my patients with unexplained arterial thrombosis, as this also may influence management, given newer data to suggest that when we're talking about anticoagulation and antiphospholipid syndrome, perhaps warfarin is a better option than rivaroxaban and apixaban. So that leads us to the final and somewhat most important step, is determining a management plan for our patients. I'll say that this is very much patient specific and thrombosis specific. So it's hard to speak generally about how to develop a management plan. And in general, the things that we are really thinking about is, what's the central question here? The question that we're often tasked with is, does this patient need anticoagulation? Does this patient need antiplatelet therapy? Or do they need both? And again, I keep coming back to emphasizing this, that there's really limited data to tell us what to do and what might be best for the patient. Because of that, the steps that I think about are, again, returning to the literature to make sure there's no organ-specific considerations or guidance on what agent should be used, doing an individualized assessment of thrombotic and bleeding risk for the patient, And then thinking about doing a continued reassessment. Because we are operating in an area without evidence, setting up a plan for regular reassessment of the current treatment plan in order to make sure it's best for the patient. So let's work through a case to illustrate how you might apply this framework into your clinical work. Let's say we have a 36-year-old female who presents with no past medical history. She unfortunately has acute left facial droop and arm weakness, and her CTA shows occlusion of the right MCA. She has endovascular thrombectomy performed and fortunately has complete reperfusion. So this patient has what I would call an unexplained ischemic stroke. This is a young patient without clear atherosclerotic or cardioembolic risk factors, has had an arterial thrombotic event in a more common site, but it is considered unexplained given her young age and lack of risk factors. The first thing I would like to do is to define the clot. So reviewing the imaging and the endovascular procedure report to see exactly where the thrombosis is located and if any abnormalities were observed during the endovascular procedure, including abnormalities within the vessel or the content of the thrombus. Discussion with radiology, the interventionalist, or neurology can all be helpful to make sure that we're all understanding exactly what's happened. If there's any insight based on what they see in their specialty that might guide them towards a specific etiology. And then looking for literature reviews and updated guidance in cryptogenic stroke. So the reality is that this is an area actually with a lot of data. And so, in this patient population, particularly when we're talking about stroke, and as a hematologist that's not necessarily completely involved in the neurology literature, it's an important opportunity to make sure that we're up to date on how we should approach cryptogenic stroke based on available evidence. So next we jump to the meat of our work, which is performing the diagnostic evaluation. So for atherosclerosis, we get a history from the patient and she reports no history of hypertension, diabetes. She is not obese. She does not use tobacco products. She does not have a family of premature atherosclerotic cardiovascular disease. She has a normal screening lipid panel and A1C. We did opt to send a lipoprotein A in this patient based on new guidelines to suggest testing in young patients with an unexplained ischemic stroke. She had imaging that did not show any signs of atherosclerosis, including a carotid ultrasound, not only looking for stenosis or just really any signs of calcification, and we did not see anything there. And the workup for embolism, her initial study was a transthoracic echo with bubble. This was without any signs of abnormalities within the heart and no PFO. Given we could not find an explanation, we did proceed with a transesophageal echo. Again, she had no patent foramen ovale and she had no presence of intracardiac material or valvular disease. We obtained 30-day ambulatory cardiac monitoring for her, opting against longer monitoring given our suspicion for atrial fibrillation, and this otherwise healthy patient was low, and it showed no abnormalities to suggest that could be the cause. We reviewed her medications. She was using a progesterone IUD, which is not associated with an increased arterial thrombotic risk. She denied any sort of non-prescribed substance use, and her urine drug screen was negative on presentation. She had a CT angiogram of the head and neck, did not show any signs of stenosis, compression, dissection, wall thickening, or anything that would make us suggest she had a vascular problem that led to her event. We reviewed in detail any systemic symptoms. We performed a physical exam, including looking for adenopathy, organomegaly, and breast masses, and could not find any abnormalities. She was up to date on her age-appropriate cancer screening with a normal pap smear 1 year prior. She had complete blood count done and it was normal and without abnormality. So we considered MPN and PNH testing, but decided to pursue other workup to not send testing for that immediately. She had no COVID infection and she had been vaccinated with the Pfizer-BioNTech vaccine. She had no family history of venous or arterial thrombosis. She had had 2 pregnancies in the past without complications and no miscarriages, because again, sometimes we can see an increase in risk with certain thrombotic conditions. She had testing for antiphospholipid syndrome with serologies and a lupus anticoagulant, and that returned normal. We ultimately did decide to pursue testing for an inherited thrombophilias, and she was found to be heterozygous for factor V Leiden. We did opt to obtain a lower extremity ultrasound to make sure she did not have any deep vein thrombosis, and it was negative, so no evidence of venous thrombosis based on our evaluation. So when we summarize this patient, she potentially falls into a category that has been evaluated in robust research, and that's the category of embolic stroke of undetermined source. This concept is really originated from the idea that within the category of cryptogenic stroke, there's a subset of people that it kind of looks and smells like an embolic etiology, but we just can't find it. And so would there be benefit in using anticoagulation in these people rather than using antiplatelet therapy? The criteria in available trials for ESIS include non-lacunar ischemic stroke on CT and MRI, no atherosclerosis causing greater than or equal to 50% stenosis, no major risk for cardioembolic source, and no other cause of stroke identified. So our patient would meet criteria for this research category. And there have been studies comparing rivaroxaban and dabigatran to aspirin in patients with ESIS. And both of those studies demonstrate no improvement in stroke prevention and an increased bleeding risk with use of the oral anticoagulant rather than using aspirin. So at this time, the current management recommended for patients with ESIS or any type of cryptogenic stroke is aspirin 81 milligrams for secondary prevention. So then we thought about for our patient, the thrombotic risk and bleeding risk. What are those things to consider? So this is a young patient who is understandably quite concerned about her risk of recurrent stroke. It would come with high morbidity and significant potential for mortality if this were to happen again. What do we make of her factor V Leiden heterozygosity? As we discussed, this minimally influenced her arterial thrombotic risk. We have no data to say that anticoagulation versus aspirin would be better for preventing arterial events. So at this point, I would not act based on this finding. I would continue with her management plan without incorporation, without changing that plan based on the factor V Leiden heterozygosity. What is her bleeding risk? In this young patient population, we always have to consider menstrual bleeding. She does have a progesterone IUD in place to help prevent that. There are many bleeding scores out there. Of course, none of those have been specifically validated in this population, but I do often turn to them to make sure we're exploring risk factors for bleeding like hypertension, renal dysfunction, and certainly modifying those if at all possible. So the treatment plan for this patient was to proceed for secondary prevention with aspirin 81 milligrams daily. Importantly, even though the factor V Leiden heterozygosity does not increase our arterial thrombotic risk to a way that we would change management, we did counsel the patient on the slight increase in venous thrombotic risk that could come with that, and talked about behavioral modification like avoiding prolonged sitting, appropriate prophylaxis in high-risk situations. She was scheduled to return to clinic in 6 months for continued reassessment of this plan, to make sure that there was no new data on that would come up or that the patient's risk for bleeding or thrombosis would not change due to additional risk factors. So I'll end here with our summary, and I hope that this will serve as a framework to help you through the challenging process of managing these patients. We spend a lot of time focusing on where the clot is and making sure that we're very thorough in considering all potential causes before jumping to developing a management plan that really needs to be individualized to the site of thrombosis and the patient's individual risk factors. And with that, again, I would like to acknowledge my co-author on this paper, Dr. Stefan Mall, who was instrumental in developing all of these concepts and has been a fantastic mentor to me. And with that, I look forward to discussion and input from the panelists as well as the audience.
All right, thank you, Dr. May. That was an incredible presentation, and I have to say the paper has some of the prettiest illustrations I've ever seen in a published work, which were included in this. So, excellent presentation.
Thank you. I appreciate it.
So, you've basically, this is extremely thoughtful and, better than the approach that I take. I generally keep a quarter with me in my pocket so that when I get asked a question about an arterial event, I can just flip it. And so, because ultimately, when it comes to the arterial system, we just don't have much guidance. And it's important, especially I think for our pharmacist colleagues on this call, to recognize that arterial and venous clots are two very different animals, that we have most of the guidance that we know and love and are familiar with, and that guide our approach comes from the venous system. When we're in the arterial system, it's a different animal, and we shouldn't make assumptions. There is legitimately significantly less guidance, less to guide. So I do appreciate the very stepwise approach here. One of the questions, I think I'll start with questions and then we'll kind of do round robin here. there was one component that you mentioned when we're thinking about conditions that can increase viscosity or some of the myeloproliferative syndromes. Often it's been debated, I think, that do just the presence of things like polycythemia vera cause an increased risk of stroke, or does it have to be associated with a polycythemia? And I could really, or with a significant red cell count or significant elevated hematocrit. And I could really take that to other conditions, things like hemochromatosis, like testosterone use. You know, do you have to have those blood dyscrasias to equate to thrombotic risk?
So that's a great question. And I think, unfortunately, we don't know the answer. I think I often use that as my initial screening tool. So I do think some of this is trying to gauge likelihood. So if, you know, in that initial workup, initial CBC is reassuring, I may not order it at that time. But in a patient that you're pursuing this workup and you still don't have an explanation and you're very concerned that that could be, you know, you're missing something, those would be the tests that I would consider. So, and particularly in the myeloproliferative disorders, the JAK2 mutation is thought to be the most prothrombotic. So some will send specific testing for the JAK2 V617F mutation. And I think the reason it's important to consider those is, I guess, when I'm approaching these patients, I'm thinking about, you know, what I would add that would change things. So if this event is due to an MPN, we need to add hydroxyurea in order to prevent future events. Aspirin is not just going to cut it. The same with PNH, we would have to add another therapy. So I agree with you. I think there's no data to tell us specifically what to do. So I start with the CBC. If I'm still not sure, I may jump back and send that testing, even if it's normal.
And that's one of the primary questions that I ask is because even in the absence of elevated hematocrit, I've seen recently the recommendation to add the JAK2 mutation. I'm actually going to ask one more question, then I promise I'll leave it to somebody else. This is what I often see is an embolic looking-ish stroke. You know, typically the typical embolic workup that I see is, to me, not complete. So I see, you know, a standard TTE, no bubbles, no TEE, you know, no evaluation of the other vasculature. No Definity contrast used to evaluate a floppy left ventricle, and yet they're like, well, it looks embolic, and so we're going to give them anticoagulation. And sometimes when pressed, they'll say, well, you know, while we do workup, we're going to put them on a monitor, blah blah blah. But when they come back for follow up, they go, they didn't have a stroke. I must have done good, so we're going to keep them on the anticoagulant. Can you speak to that approach and kind of maybe how we could, if you know, push back on that?
Yeah, I think that's a very common observation, and certainly, right, it's hard because I do think we have some data to support that may not be the best approach, and it is those trials that we cited that, you know, this ESUS category, which is not necessarily a clinical category we follow, but in the research perspective, these were the patients that it looked to everybody thought this was going to be embolic and anticoagulation was going to be the right decision. And these patients had an increased bleeding risk and didn't have a benefit for preventing stroke. You know, it may be the anticoagulation is helping prevent the stroke, but the problem is that it's also coming with a bleeding risk that aspirin may not have. And so in that situation, I do think it's important to partner with each other to say, hey, can we, you know, what are the additional tests we need to pursue to make sure we've ruled out embolism? And if we don't see any sign of embolism based on available data, I think we should consider switching back to aspirin.
Yeah, extremely important. I think that, you know, we take trials like the APS trials, these small trials, and we make big decision-changing categories, but we forget these are large negative ESUS trials. The rivaroxaban trial had 7,200 patients in it, and it was a negative trial, and yet we don't seem to apply it the same way. So, yeah, thank you for those. Deb, what do you have for us?
If it's okay, I'm just going to stick with a similar theme. I'm just reading through the comments, and then there were some, you know, really good questions submitted, you know, at registration before. Just to maybe tease out a little bit further about the issue of anticoagulation, and particularly direct oral anticoagulant. So we kind of talked about ESUS as an entity with ischemic stroke, but I wonder a little bit about other types of arterial events, and really you know, splenic or renal artery infarctions. Peripheral arterial disease, I think, is a scenario where we have data about the use of combination aspirin and very low dose, but maybe just to touch upon that a little bit, because there's a few questions about, you know, that is a common scenario. And often we see anticoagulation being given. One of my colleagues is quite, we have some, casual disagreements with our colleagues about, he's like, a renal infarct is an ESIS of the kidney. And so he would not put people on anticoagulation and would put them on aspirin for that. So I just wanted to get a sense of, do you sort of think about those events in the same way as ESIS? They are different, but perhaps maybe just to talk about that a little bit.
Yeah. So I think that's a great point. And I think the important thing there is, right, clearly all of these people with this thrombotic expertise continue to debate with each other. So the challenge is that there is no right answer. But I think that is what I try to emphasize, is that I think every organ system of arterial thrombotic event is different. And so I think it's really hard to generalize data from ESIS to the renal circulation. So when I think about, a renal artery infarct, I think about, yes, embolism is actually the leading cause of a renal artery infarct. And so I look really hard for a reason to put the patient on anticoagulation to make sure, there isn't a source of embolism that I could be missing. So I think it's hard to be dogmatic to say, what's right in those areas. And what I try to do is, what available data is there? What is my biggest suspicion? But recognizing that, using anticoagulation comes with risks. And so trying to be very deliberate if I do choose to use it. I'm interested to hear your approach as well.
Oh, me? I'm similar. I'm not quite convinced that a renal infarct, I don't treat renal infarct as an ESIS of the kidney in the same way that my colleague does. But I do as well. We really is a matter of looking for an underlying etiology. I spend a lot of time doing that. I think in my practice, I have routinely put people on anticoagulation for, while awaiting the results of some investigations. Not everybody does that. So that is not an evidence-based approach, but, we know that people who have TIAs or strokes are at very high risk of having recurrent TIAs or strokes very shortly after that event. So that's kind of what influences me in that direction. So I do the same thing. The other scenario that I just did want to mention that we get asked about a lot, if it's okay, I'll just take another minute, and then we'll let Andrea have an opportunity to ask questions. But it's become a research interest of mine, and it's a common clinical scenario, is patients with a cancer diagnosis who have ischemic stroke. And we get asked a lot, and there's, again, very little evidence to guide, decision making. Do standard therapies work as well, in patients with cancer who are quite hypercoagulable, as we know? Do you treat those patients differently?
Yeah, that's the challenge. There's always been this back and forth debate of, does, stroke in a cancer patient require anticoagulation rather than antiplatelet therapy? I think a lot of times part of my decision is really bleeding risk, because what you worry about often in cancer patients is they're getting chemotherapy that's going to cause thrombocytopenia, or they have organ involvement, may increase their bleeding risk. And so, potentially in a patient that has a very low bleeding risk, I may consider anticoagulation, but in general, I tend to lean on antiplatelet therapy, particularly just worrying that I'm adding the potential for bleeding without any clearly demonstrated benefit.
Yeah, I'm glad you brought that up, Deb, because I've seen that as well. A while back, I was seeing, any patient, almost any cancer patient that suffered a stroke, and in some cases, even if it did not have components of embolic looking components on the imaging, we were seeing low molecular weight heparin used. And I was like, well, where is this coming from? And it was being extrapolated from venous thrombosis in cancer-associated patients, or in cancer patients, back when that was favored, which of course it no longer is in the last few years. But yeah, I have to wonder if cancer-associated stroke is a thing, and we're leaning on you to help define this for us. And no pressure.
No pressure. No pressure. So I'll throw in a question. Sorry, excuse my voice. Is there ever a reason in a patient to combine an oral anticoagulant with an antiplatelet in these sort of situations? Is recurrence of events triggering you to do that kind of a thing, or patient characteristics? Like when would we combine those two methodologies, or treatment therapies, I should say?
Yeah, so that's a great question. Particularly in a patient that, you're very concerned about recurrent thrombosis, is there any benefit to using both of these together? Again, we're kind of in a space without data. I will say in antiphospholipid syndrome, there are some who take the approach of, in patients with stroke, using anticoagulation with antiplatelet therapy. There's some small studies that have maybe indirectly assessed that, but there's some concern that anticoagulation alone may not be sufficient to prevent those events. Outside of a specific severe condition for initial management, I often try to stick with single agent. But certainly if we have a patient where we've taken one approach and then unfortunately they have a recurrence, that's often where I consider going next, is using a different mechanism of antithrombotic therapy. So adding anticoagulation or antiplatelet therapy where one may not have been there. Of course, at that time too, reassessing if there's an etiology that we miss, I think is the most important, rather than stacking medications that may come with bleeding risk. But I do have a couple of examples of patients where, we started with an initial management plan that was unfortunately there was a second event and we added an additional agent, and that's been successful moving forward. But trying to avoid that if at all possible, given that we do know that as we add those agents, the bleeding risk will significantly increase.
Absolutely. This makes me think of a patient of mine that just kept having these TIA-like episodes, was on anticoagulation plus antiplatelets, still breaking through. And so, after communication with colleagues, I said, is this maybe more of like a seizure-like activity? So then collaborating back with the neurology team to do further work up there. Ultimately, we did end up taking him off of his Eliquis because we said, that really, he had no demonstration of AFib. We had, there was no other marker, and he kept having rectal bleeding. So the bleeding risk, I don't think we can forget about. We have to really consider this. And I always, another management strategy is it's never forever with anticoagulation. Always reassess. Is there something we need to change? Something we need to modify. So I'll toss it back to you, Arthur.
Yeah, thanks. Really good discussion about the question of combination therapy. And some of the things that I get concerned about, to kind of go back to something that I think Deborah mentioned earlier, is when you have, for example, our vascular colleagues who are trying to salvage a limb and they're using therapeutic anticoagulation in a patient with clearly a background of bad PAD, and because they're on an anticoagulant, they don't use antiplatelet therapy. I question that approach because these are classically atherosclerotic events, and antiplatelets are the mainstay of therapy. If it was my leg, I would probably be on antiplatelet therapy, even if there was someone was insisting that I be on an anticoagulant. Do you have similar concerns about that?
Yeah, the peripheral artery space is tricky because it is an area where there is some data to guide management. And I think Deb alluded to this. I'm really intrigued by the concept of dual pathway inhibition. So the idea of maybe using a lower dose of anticoagulation with antiplatelet therapy. So that approach that's been demonstrated using rivaroxaban 2.5 milligrams BID with antiplatelet therapy. I think the hard thing is that we put these drugs into categories. This one's an anticoagulant and this one's an antiplatelet, but we know there's overlap, right? So anticoagulation has some ability to affect primary hemostasis and coagulation and vice versa. Aspirin is used for VTE prevention in orthopedic surgery. So it's hard to know. I do think I often, work closely with my vascular colleagues just to try and think about, what are their concerns from what they see? Is it bleeding risk? Is it thrombotic risk? How can we strike a balance? But I do like the idea of hitting both of those pathways, if at all possible, in the peripheral arteries.
Yeah, I almost aged myself by saying white clot and red clot, but I decided not to because I think that's not really a thing anymore. So.
Oh, I totally understand. I think that way too, but I have to force myself to say, we know more now, right? We understand that these processes do not happen in isolation. There's interplay between the two, and so it's interesting as we continue to learn more how that influences how we pick agents.
I always like to tell the trainees that coagulation happens on the surface of the activated platelet. So it helps, these people sort of remember, visualize that there's such an important interplay. So I totally agree with that. And we're seeing more and more of that being used, but sometimes it's outside the scope of hematology anyways, but we do get drawn into those scenarios. I wanted to there's a bunch of questions about testing and maybe just because that's our hematology expertise, testing is thrombophilia testing is a really controversial aspect of our job. And they're often, we think about thrombophilia testing when you mentioned this too, Jori, like when we think the test result will change management, it's helpful to do. Not everybody understands how it will change management, and anybody can really order thrombophilia tests. So I guess a question would be, how would you approach the issue of thrombophilia testing? You alluded to this in your slides where it was like one of the last things that you do. So I like that, because I feel the same way. But even practically speaking, like there's some cautions around testing while people are on anticoagulants. And there was a question, also good question about lupus anticoagulant and does that affect point of care device INR testing? And so just those kind of practical aspects of testing would be helpful, maybe, to discuss.
Yeah, absolutely. And I think they're so important, is because not only understanding why you're sending the test, but when it can be wrong and when it's actually accurate. So when I think about, if I have a patient coming to me who's on anticoagulation, what if I did want to test for inherited or acquired thrombophilia, what can I send? And I think about it, I can send genes and antibodies. So factor V Leiden and prothrombin are genetic tests, so that's not going to be influenced by anticoagulation. And if I'm concerned for antiphospholipid syndrome, I'll send the 4 antibody assays that are recommended in the revised Sephora criteria. So that's the anticardiolipin, IgG and IgM, and the anti-beta-2 glycoprotein 1, IgG and IgM. Particularly if I'm worried about antiphospholipid syndrome, I find that to be a really helpful first step if a patient is on anticoagulation. If I have a really high clinical suspicion and I do feel like I need to test, we have to take people off anticoagulation to get a reliable lupus anticoagulant and to get a reliable protein C, protein S, or antithrombin activity. I will add, testing for protein C, S, and antithrombin is really tricky. And there was actually recently a new publication that our current approach for testing for antithrombin deficiency is probably insufficient, that there's probably new genetic testing we need to be doing. So I don't jump to those unless I have a really high clinical suspicion. But I do try to think about doing it in that stepwise approach if a patient is on anticoagulation. If a patient's on antiplatelet therapy, right, we don't have those limitations to those assays. But hopefully, Deb, that gets to the question you were trying to ask.
Yeah, I have a similar approach, but I sometimes we've all been burned by doing testing and getting results of tests, and we're like, I don't know how to deal with this test result. So it is just it's just important to keep that in mind. One of the things that we hadn't talked about, which I just wanted to mention briefly, is so sending off antiphospholipid antibody testing, even early on, and I have had this personal experience in hospitalized patients, there's a high prevalence of them, particularly IgM, and they're not very well associated with thrombotic events. But, so I had a patient where I ordered antiphospholipid antibodies for an unexplained, combined DVT and stroke. And so we should have done the echo first, because the transthoracic echo showed a PFO. And I was stuck with this result with a high IgM, not knowing how to IgM anticardiolipin antibody, so not knowing how to interpret that. So just, again, it doesn't mean that you can't order these tests. It just means, I think, that the point is to be thoughtful about it and just make sure you understand the implications of the testing. And for patients and their families, it causes so much anxiety for families. And often it doesn't change anything that we do. So it's just really important to remember that.
Yeah. And I'll add to that, I've definitely been burned in that same way. And so I really put it at the end of the algorithm to force myself, not because I'm a hematologist, right? That's obviously what I want to jump to. And so particularly in that initial stage, really focusing on the workup for other things, I think is the best way to serve patients. And if, you're really down the line, so we're talking outpatient, right? So rarely are we ever sending these tests when patients are in the hospital. This is in follow-up after, 30-day cardiac monitoring, after these things. Antiphospholipid syndrome, I may send a little bit earlier, but your point is really important, right? Particularly the acute inflammation with acute issues, those numbers can go up. So keeping that all in mind before you pull the trigger on these tests, I think you'll thank yourself for doing that in the long run.
Yeah, actually, just for funsies, I think this would be interesting. I'll go to both Dr. May and to Deb. What percentage of your time do you, when addressing the question of thrombophilia, what percentage of your time do you say don't, or do you spend undoing inappropriately drawn or inappropriate assumptions that have been made based on thrombophilia testing already done? Dr. May.
I have that actual percentage. I think, can we put it at like 80 or 90%? I think that's probably my wheelhouse. What about you, Deb?
Yeah, I totally agree. We often will see people, we sent off this test, it was positive. Now what do we do? We have to undo, that.
You shouldn't have.
It's really, really difficult. We spend a lot of time. It's really difficult. And I can also say that, there is a lot of value in counseling around the issue of testing in the first place, but it takes a lot of time. These things are not intuitive to, clinicians, let alone patients. You have to sort of explain the rationale for not doing something. It takes like way longer than just sending the test. But I think that is super value added for patients and families. And I stand by that approach. Yeah. And most of the time I recommend against, like most of the time we don't test, and people actually are okay with that, if you explain it.
And that's what I was going to add. I think a lot of times I have conversations with patients and they don't necessarily want to test. I think we assume that, patients want every test done or every, thing done. But oftentimes if you sit down and share with them the lack of, what are we going to do with this information, they tend to reach the conclusion that they don't necessarily want those things performed. So I think it's important to always talk to them first before sending that testing as well. And I will highlight the British Society of Hematology guidelines that just came out on this topic are really quite interesting. I know ASH is developing some as well. So I think it'll be helpful to have some clear guidance statements on this as well. Hopefully that will give providers a little bit more of a tool and some reassurance that we don't need to order these. Certainly guidance documents alone will not do that. I think there's system level things we can do as well, but I encourage you to check that out if you're interested.
The Anticoagulation Forum, the AC Forum, has a guidance document that I sent to a lot of trainees. It's, I think, from 2016. I don't know, maybe someone can put a link in the chat, but it's actually really helpful because it walks you through the rationale for why test and why not. And I actually think, it's worth the read for sure, to be able to have that language, to talk to patients, to explain your decision and make recommendations is really good.
Yeah, and then we also have our new rapid resource on the thrombophilia testing, which I think we linked earlier on, and it's awesome. I keep it like on my favorites and click on it frequently. And I actually showed a patient sometimes when we talk about, how do we interpret testing? And so, yeah, there's so many good resources. If for our viewers, if you haven't already checked out all of our rapid resources and our anticoagulation centers of excellence, please go there. Lots of tools at your disposal. So I hope I'm not going to steal Arthur's question, because I think he's going to think about asking about warfarin versus DOACs. So in these arterial events, excuse me, I'm recovering from COVID myself. So how do we select warfarin versus DOACs? Arthur, I hope I'm not going to steal your thunder.
So that's a great question, and something I think a lot of us face pretty regularly. I will say in a patient with an unexplained arterial event, when I'm making that decision, given I don't have data to necessarily tell me anticoagulation is right, I definitely don't have data to tell me if warfarin or a DOAC is better. And so I will often go to a direct oral anticoagulant. If I don't have data to show me that warfarin is somehow better than those agents, I just think from a quality of life perspective, from a patient management perspective, from an ability to comply perspective, sometimes that's easier for them. The cases where we will want to use warfarin, and the reason we talk about testing for antiphospholipid syndrome is in patients with antiphospholipid syndrome. So the studies have compared rivaroxaban and a smaller study looking with apixaban to warfarin, and those patients appear to have, those on rivaroxaban or apixaban appear to have an increased thrombotic risk, particularly arterial thrombotic risk. There's a lot of debate in the hematology world. Is it everybody with antiphospholipid syndrome that should be on warfarin? Or is it only those really patients that we worry have really high thrombotic risk, those triple positive patients? I think there's plenty of hematologists out there who have patients with antiphospholipid syndrome that have been on DOACs and are doing okay. And I think some people say, well, if they're on it, continue it. My current practice at this point is if I have a new diagnosis, I do favor using warfarin. But I will have an informed conversation with the patient, particularly if we're talking about a single positive, one serology that's abnormal, low level positivity, that's the patient I might talk about it. But remembering that one of the studies, the Ordi-Ross study that looked at rivaroxaban versus warfarin, was not only in triple positive people. The risk of thrombosis appeared to be not predictive based on serologies. So I think this is an area that's developing, but is hopefully we're going to have more literature to guide us in the future. But for right now, that's the one population where I really think about warfarin. Otherwise, in the absence of specific studies to tell me it's a bad idea, I stick with the DOACs for patient convenience.
Yeah, thanks. Yes, you did steal my thunder, Andrea, and I'm gonna hunt you down. No, so you bring up exactly what I was going to say, which is, with the exception of dual pathway inhibition, this entire talk has been off-label. Is that correct? Is there anything that we've talked about that's not off? Okay, so
I probably should have started with that.
Yeah, so there is a lot of questions that came in. Can I use a DOAC in general for arterial? But some of them are about, what if they have APS? What if they have other thrombophilias that are not APS? So the blanket statement is it's off-label for everything. In some cases, we're kind of making it up, which we don't like saying out loud, but in some cases, when we're off in left field, we don't have a lot to guide. Does it really make sense to make it up with one drug over another, just because we have a history of, the only reason that warfarin was used in any of these settings because it was the only drug available, right? And so there are situations where you ask two questions. One, do I have proof that warfarin is better? And two, do I have proof that DOACs are a bad idea? Right. So I think about things like triple positive APS, smaller, weaker studies, but warfarin, perhaps. And I think about things like ESUS, negative trials with DOACs, or any anticoagulant, if we're being honest, right? And so that's how we should really think about these. As far as other thrombophilias, there's no reason to believe necessarily that we shouldn't. And when it comes to APS, we may, based on what was said earlier, that we can't really test on anticoagulation for lupus anticoagulant. Sometimes the best we can do is test beta-2-glycoprotein and cardiolipin and go, well, one of them was negative, so at least we know they're not triple positive, right? That's sometimes what we're stuck with. So I could talk about this all day, but Liz is going to fire me. So I'm going to kick it back to Liz to finish up. Thanks again, everybody, for the great comment, great conversation, great presentation.
Thank you so much. Wow, this was a phenomenal discussion. Jori, what a clear and helpful presentation in this area. Arthur, as you said, that there isn't a lot of guidelines or guidance. So having experts debate is really helpful to our members. So thank you all for volunteering your time today. As Arthur said at the start, this is accredited. So the link is in the chat and you can always go to our website to claim your credit. Please join us for our next webinar with Arthur and Deb, again, our amazing webinar team, and Thalia Field speaking about anticoagulation treatment of cerebral venous thrombosis. So please join us August 22nd. Registration is not live yet, but it will be soon on our website, and we'll be sending out an email. As everybody mentioned, our rapid resources are phenomenal clinical guidance. They're 1 to 2 pages covering all sorts of topics. I think we have 20 or so. So please go to our Centers of Excellence Resource Center. The link is below, and check out all the rapid resources. And there's one specifically we're highlighting here on various VTEs, but also, as I mentioned, there's thrombophilia testing and tons of resources there. So please take advantage, and it's all free. We have another virtual boot camp coming up. It will both be live during those 2 days and then enduring for about 30 days after. So please join us for that. Registration will open soon. And our conference, our national conference, is in early April in San Francisco, where all 4 of these amazing speakers will be there speaking. Jori will be speaking on this topic at our conference. So please save the date and join us there. And one more conference, THESNA, is next month, and AC Forum will be there. And there's lots of board members and lots of topics that should apply to your practice. And lastly, I would just like to thank all of our corporate sponsors that support this webinar series and the AC Forum in general. So thank you all for taking the time out of your day to join us for this webinar, and have a great rest of the day and stay cool. Thank you, everyone.